what does diagnosis mean? Like, what is a diagnosis? And
Yeah.
the clinical perspective is very much it's differential diagnosis. It's what are the most likely causes of this thing? What's the statistically most likely outcome or cause
Yeah.
for this particular symptom or presentation? But from patients' perspectives, it's viewed completely differently. If they sort of say, okay, well, I think it looks like asthma, it's most likely to be asthma
Mhm.
as a clinician. So they treat for asthma and then the symptoms don't let up. In fact, they get worse. Okay, so it's not asthma. Go back to the drawing board. And that's a differential diagnosis for the clinician. But for the patient, it's they've mishandled me. They misdiagnosed me.
Mm.
I feel let down because they're not knowing what it is, and doctors fix things.
Welcome to Cardiomyopathy Conversations, the podcast where we talk to medical experts and patients about all things cardiomyopathy, brought to you by Cardiomyopathy UK, the UK's foremost charity for heart muscle disease. Don't forget, if you enjoy this episode, to hit the like and subscribe button so we can notify you of every new episode. If you want to find out more about cardiomyopathy, check out our YouTube channel at youtube.com/Cardiomyopathy UK, or take a look at our website at www.cardiomyopathy.org. Welcome everybody to this latest episode of the Cardiomyopathy Conversations podcast. It's Libby here, and I am delighted today to be joined by Jenny Taylor. Jenny may well be known to some of you. She's an assistant clinical psychologist. She's a PhD researcher and has recently written a PhD all about the clinician and patient perspectives on diagnosis. And she is also a patient living with DCM. And Jenny and I are going to talk today all about diagnosis. So Jenny, welcome to the podcast.
Thank you very much for having me.
It's a pleasure to have you. Jenny, I thought we could maybe start by you telling our listeners about your experience. So you have dilated cardiomyopathy.
Mm-hmm.
Talk to us about your experience of diagnosis as a patient.
Yeah, so my experience of diagnosis, I suppose, is quite limited, especially compared to other people, the people I've researched, for example. I was diagnosed at 6 weeks old with
Wow.
dilated cardiomyopathy after I had a bit of a ongoing cough. Um, I was taken to hospital and found to have fluid leaking onto my lungs, a bit of a leaky valve going on, and it's because my heart was actually sort of dilated and stretched. It was stretching the valve, making it leak, and that sort of dripping onto my lungs was causing the cough. So yeah, that's how they found out about my diagnosis.
Wow.
Um,
So I suppose in a way, I mean, you knew that you had it as you grew up, really. So it wasn't something that you had to get used to having or was a shock or came out of the blue. You sort of developed with it.
Yeah, absolutely. And it's funny, I describe in my thesis, you have to sort of put about your positionality as a researcher. And I do sort of describe in there that I was really interested to hear about the perspective of the patient that has lived a quote normal life and then gets hit with the diagnosis, because for me, that's the complete opposite to my own experience, where it was
Mm,
kind of weaved into the fabric of my reality from day one,
mm,
all of this sort of medication and hospital visits and flu jabs, and it was just normal. Whereas for other, people, I suppose I didn't realise it wasn't normal until later on in life.
I guess for a number of people, there will be the self before
Yeah.
diagnosis and then the self after diagnosis and the adjustment
Yeah.
of that. That wasn't the case for you, was it?
No, no, not at all. And you can sit and consider, what would I be without a diagnosis? Where would I
Yeah.
have been now had that not been the case? But I've got to say, I'm very grateful for the fact that it was the case, because
Mm,
I think it's meant that I don't have that sense of loss that I think some people have
yeah.
when they get diagnosed. They have a very sort of felt sense of, well, we'll talk about it a bit more uh, as we go through this conversation, I'm sure, but there is a sort of sense of loss and a change of that sort of self identity, like
Mm,
you say, that I didn't really have to go through. It was more of a oh, I'm slightly different to my peers.
Yeah,
Maybe that's
yeah.
the evolution I went on as a alternative.
That obviously inspired your journey as an adult, and now as
Mm,
a assistant clinical psychologist, and the opportunity now to do this PhD, looking at just that. I know in your PhD you looked at both the clinician perspective of diagnosis and the patient perspective. I thought maybe it would be helpful for our listeners if we started by talking a little bit about the PhD itself. So
sure.
it's a qualitative piece of work,
It is.
and
Yep.
we use big words like phenomenology and IPA and
Yep.
epistemology and all of those kinds of things. Put it into ordinary Libby type normal person terms
Yeah.
for us, so that we can get an understanding of what the thinking and what the theory behind the PhD was.
Yeah. So, I mean, all those terms are just sort of very fancy ways of saying very simple things, really. So, um, the the research was qualitative, in that it was about people's experiences. It was the lived experience of being a cardiologist diagnosing cardiomyopathy or being a patient diagnosed in adulthood. I did use interpretive phenomenological analysis, which is a type of analysis which is a mouthful and a nightmare to say, but that's IPA.
Yeah.
And basically, all that
People listening
means,
will think that that's actually a type of beer.
oh, it should be. But
Yeah, I feel it's a type of beer for
oh,
sure.
oh, is it?
Yeah,
Oh, what's else?
pale
I didn't
ale.
know that. I didn't realize that. That's great. Love it. I've got beer in my thesis.
There you go.
But yeah, so basically, all that means is that I understand that people have very sort of subjective experiences, myself included, and that I, as a researcher, am a part of the narrative that I'm telling. So I am understanding what they're telling me, they're understanding their experience, and I'm telling my interpretation of what they interpreted through that experience. And
Yeah,
so there's like a multiple layers going on, is all that kind of means. Um,
well, I think part of what you're saying there is that you, as the researcher, you lay your cards on the table
mhm,
at the beginning, and you say, "This is my perspective.
yep,
This is my bias in a way. This is what I'm coming."
absolutely.
Because when I interpret what you're saying to me, when I will interpret it in a particular way, but that's okay. I'm going to lay that
Mhm.
out there and say to you,
Yeah.
this is what I'm doing, and this is how I'm going to interpret it. Essentially, isn't it?
Essentially, yeah, and I think people will, in academia, will perhaps disagree or argue with this sort of perspective, but I personally feel that you can't take the human out of humanity, and you can't really sort of get away from that in qualitative research and analysis. I think
Yeah.
you're always, whoever you are, whatever your background, are going to come in with certain biases or certain schemas and ways of thinking about the world that affect how you interpret things. And
Mhm.
it's just being really open and honest about that from day one.
Yeah.
Obviously, we didn't want it to affect the research in a bias as such. We would, so we did do things to sort of mitigate that. I had a team of supervisors that would sort of regularly check in and analyze the same thing, and then we'd come in and check that they matched, and in a similar way, and that I wasn't sort of going off on a tangent because of my own background. Um but yeah, it's been really interesting to have that experience and come into the research being able to relate to the patients
Yeah.
as well in
Yeah.
that way, because we have got some level of shared experience, I suppose. um but what was interesting was that I decided as a researcher not to divulge that I was a patient to the clinicians,
Oh,
but I did
really?
to the patients.
Oh, that's interesting. And why did
Yeah.
you do that?
So I did that purely because we decided that patients would immediately feel more at ease, more
Mhm.
comfortable
Mhm.
when they're talking to someone who they kind of think, yeah, you get it. I can just say it and it doesn't sound silly.
Yeah.
I think, and in order, if we're speaking about truth, aren't we? We're speaking about people's honest,
Mhm.
lived experience, and I wanted all of it, warts and all.
Yeah. Yeah.
Tell me everything. So that, I think, really helped with that relationship. Whereas I think speaking to clinicians, I think it would have hindered that conversation because they would have perhaps been scared to say certain topics in case it upset me, or
Yes.
they would perhaps put on their I'm speaking to a patient voice. And I really was glad I chose to do that way, because part of the things that they then said was about this kind of, oh, I have to put on this patient voice, or I have to just drip feed information, and
Yeah.
so it's really sort of, they wouldn't have told me that otherwise as a patient.
I was just
um
going to say to you, actually, you've probably hit on what one of the key issues, haven't you, about the whole perception of diagnosis from these two different viewpoints, is that
yes.
the clinician viewpoint is laden really with responsibility, um, preconceived ideas about how somebody might receive something,
Mm,
or how they might have to act as a clinician. I noticed that one of your clinicians, we'll come on to this in a minute, but they talked
mm,
about it being a theatrical performance.
yes.
And I
Yeah.
thought that was a really interesting analogy. It's like I'm having to put my performance hat on now, and that's how they see that diagnostic episode. Totally different to how the patient perceives it.
Yeah, yeah, absolutely. And the very last chapter of my thesis is integrated findings, where I literally take key issues that have sort of either be really divergent or convergent
Yeah,
between the clinician and patient perspectives, and discuss that. And one of those things is definitely, what does diagnosis mean? Like, what is a
yeah,
diagnosis? And
yeah,
the clinical perspective is very much, it's differential diagnosis. It's what are the most likely causes of this thing? What's the statistically most likely outcome or cause
yeah,
for this particular symptom or presentation? And but from patients' perspectives, it's viewed completely differently. If they sort of say, okay, well, I think it looks like asthma, it's most likely to be asthma
hmm,
as a clinician. So they treat for asthma, and then the symptoms don't let up. In fact, they get worse. Okay, so it's not asthma. Go back to the drawing board. We'll go, and that's a differential diagnosis for the clinician.
yeah,
But for the patient, it's they've mishandled me. They misdiagnosed me.
mm,
I feel let down because they're not knowing what it is, and doctors fix things, so they both come in with this sort of preconception of
yes.
what might
What
be
they
going on.
expect from the relationship.
Yeah, yeah,
Yeah,
yeah, absolutely. um
expectation.
Yeah, and the expectation from the clinical side is sometimes that they don't expect too much from patients, and the expectation from the patient side is that they expect the world from their clinicians.
Yeah,
And if clinicians don't know the answer straight away, if cardiologists kind of go, "I'm a bit stumped here,"
mm,
patients don't really know what to do with that, because that goes against their preconception of, "But you know everything."
yeah, 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 yeah. It's fascinating, Jenny, and I will pick up again on that in a little while. But
Mm,
so if we just think about the clinicians that you spoke to,
mhm.
um, what kind of clinicians were they? Were they consultant cardiologists? Were they GPs?
Yep. So we specifically targeted consultant cardiologists from tertiary cardiac centres within England.
Okay.
So we did that purely because cardiomyopathy is quite a common condition in some ways.
Yeah.
Prevalence of around 1 in 300, 1 in 250 people, depending on who you ask. But a lot of the way that the system seems to work is that the diagnosis gets sent to secondary care specialists or to these tertiary cardiac centres, where we felt that they just had the most frequent kind of interaction with cardiomyopathy cases, with cardiomyopathy patients.
Mm.
um, they have whole ICC clinics, the inherited cardiac conditions clinics, set up in tertiary cardiac centres. So we decided to sort of target specifically those hospitals, those clinicians, so that they had, the most experience to offer.
In your findings from your conversations with those clinicians, what would you say were the key points that they raised regarding their experience of giving a diagnosis of cardiomyopathy? What were those key issues that sort of spanned all of them?
Broadly speaking, there was two sort of main themes that I found. And one was this felt sense of frustration from the clinicians. This, I've called it ideal versus real. And
Hmm.
it's the idealistic kind of notion of care that they would love to provide, but feel that they can't because of systemic or intrapersonal issues going on, these barriers that get in the way of them being able to provide the care that they feel they should. be
Mhm.
able to. The other one was barriers to shared decision making. So shared decision making was highlighted as a really important part of diagnosis. And the thing that I loved to see actually was that historically diagnosis was seen as a bit of a conversation. It was the point at which the patient's told you have this
Yeah.
condition. Whereas through the research, it was really lovely to see that diagnosis was absolutely, from a clinical standpoint, considered to be a journey. It's a
Mm.
series of interactions with medical professionals. It
Mhm.
wasn't that kind of older model of care seems to have been changed now, which is
Mm.
great to see that there is an understanding that patients go on a journey, clinicians go on a journey with
Mm.
patients in order to reach diagnosis.
I think that's really interesting, Jenny. And I think one of the things that struck me looking at your work was you mapped out what the clinicians thought of as the ideal patient pathway.
Hmm.
Um, and in that pathway, so I'm just going to briefly summarize and correct me if I'm wrong here, but we're talking
Yep.
about identifying the patient,
Hmm.
the diagnostic testing.
Yep.
Then they give patients given a diagnosis and referred to a specialist consultant cardiologist,
Yep.
who then refers to a specialist heart failure nurse.
Hmm.
Heart failure nurse identifies the patient's needs, i.e., cardiac rehab, charity information resources, that kind of thing. And at the end of that ideal pathway that the clinicians had espoused, it said patient needs met and service needs met. Nowhere in that pathway, and bearing in mind now that we know that these clinicians are from tertiary centres,
Hmm.
nowhere in that ideal pathway was there any mention of genetic testing, family
No.
screening. The entire steer was towards the heart failure world. I
Yes.
have to say, I was fair nigh shocked by
Yeah.
that. Talk to me about that, Jenny.
Yeah. So it's interesting, isn't it? I mean, there was a lot of talk about sort of, obviously I'm not medically trained as a sort of in my clinical background, so I was speaking to them a bit about, well, what kind of cardiomyopathies do you see, how do you tell which one they have, and all of that sort of stuff. And obviously the genetic side of things came up then, but yeah, it was very interesting to see that a lot of it was, there was a bit of this sort of silo working culture where they would kind of go, well, my job is to just do this
Mm,
and then pass to this person, and their job is to do this and pass to this person. And it was very interesting because in a way that kind of works quite nicely. Everyone knows what they're responsible for, but then when things go wrong, it's like, oh, but the system's broken, but it's not my responsibility to fix it.
yes, yeah,
um,
yeah,
and which is interesting. But yeah,
yeah.
it sort of echoed the wider sort of issue that's going on with research in this area as well, which is that cardiomyopathy patients experience X, Y, and Z, actually come from broader sort of heart failure research.
Yeah.
The cohorts are of people with heart failure,
Mm,
and it doesn't often go into specify, okay, yeah, but how many of those had heart failure caused by a cardiomyopathy versus
mm,
something else?
yeah,
So I was really sort of, that's kind of been eye opening for me doing the research, was, trying to find very specific papers
yes.
on cardiomyopathy patients specifically.
Mm,
Um, and some of the clinicians took a lot of issue with using how they can see other clinicians using heart failure and cardiomyopathy interchangeably when they're talking to
mm,
patients.
mm.
But then they would do that themselves in the interview.
Listeners might be interested to know that we have done actually a whole other podcast episode on the difference between cardiomyopathy and heart failure.
Yeah, well,
And I think that you can have cardiomyopathy and not have heart failure,
yeah,
and you
absolutely.
can have heart failure and not have cardiomyopathy.
Hmm.
But I think for me as a layperson, looking at how things are moving in the world of cardiomyopathy, it is for sure going down quite a distinct genetic route,
Yes.
because there are so many now identified genes
Yeah.
that link to specific cardiomyopathies, and the identification of those genes absolutely direct therapy.
Yes.
And if there is no consideration of the genetic aspect of the condition, then the clinicians are really, I think this is the point where the patient might go, hang on a minute, you failed me there.
Yeah.
You have actually failed me because I've come to you as the specialist in the
Hmm.
tertiary centre, no less,
Yeah.
with ICC nursing teams and clinical teams, and actually their ideal pathway, it has no mention of genetics and family screening.
The fundamental issue as well that I saw was when we have this model of, yes, my job is to identify this and then pass you on to this person who will do X, Y, and Z. When we have that kind of model, it all starts with primary care. And so it's got this kind of assumption that GPs know what to look for.
Yes.
It's got an assumption that GPs are aware about cardiomyopathy,
Yeah.
and how it differs to heart failure, and which is not always the case, you know?
And actually, how the cardiomyopathy patient might present. So
Yes.
traditionally, as you'll be well aware of this, Jenny,
Mm,
heart failure patients tend to be older.
yeah.
And the concept of having a younger person
Yeah.
sitting in a GP surgery saying, I'm breathless, and, you don't, automatically think heart failure and or cardiomyopathy. Um,
Absolutely.
you
And
know,
that's the thing, you see. So the clinicians would say to me, the cardiologists would say to me, yeah, but there is a bias. It's a true bias. One of them said, you know, and I
hmm
thought, well, yeah, but this is where it comes back to, because I mean, yeah, essentially, if you have a 20-year-old come into your GP and say to a GP, I've got breathlessness and I've got, sporadic chest pain and feeling a bit tingly in the fingers, they'll say, oh, bless you, you've got anxiety.
yes,
You know, it's hard being young nowadays, isn't it? You can't buy a house. There's all these things. Of course, yeah, it's probably anxiety, love, you're fine. It's difficult, I think, but that's a differential diagnosis, isn't it? For them, they're looking at the symptoms presented and think within the wider context of the conditions that they're aware of and they know about and
yes,
they're very educated on. It's not as likely to be cardiomyopathy or something wrong with their heart.
mm,
It was more likely to be asthma, anxiety, all these things that people tend to get misdiagnosed, quote,
mm.
um, with first.
I think this is one of those areas where, and the Cardiomyopathy UK have been putting forward this concept for quite some time now about the importance of a family history.
Yes, absolutely.
And that young person might rock up at the GP with all of those symptoms that might take you down the route of anxiety,
Mm,
asthma, but actually on the background of a family history of cardiac issues, it might take you down a completely different route.
yes,
So I
absolutely.
think it's just being alert to that, isn't it,
Yeah.
in general practice? But I think one of the other things that I thought was really interesting from the sort of clinician perspective was that they felt bound by the system that there were systemic
Mm,
issues that meant they couldn't provide the level of care that they wanted to provide.
yeah.
And yet when we look at what the patients told you about their experience of diagnosis, one of the things that struck me about what they said was that they talked about this doctor robot.
Yes.
Yeah. So
Yeah.
a dehumanizing care. So they
Yeah.
became you talked about a body over self. So,
Yeah.
a list of symptoms rather than a person. And
Hmm.
I think one of your participants actually quoted, I'm a person, not a condition.
Yes.
And I think that's interesting because obviously we understand that the clinicians see the system as part
Mm,
of what's stopping them from giving the patient good experiences of diagnosis. But from the patient perspective, actually, what they want,
mm,
in terms of what we found with your research, is
yeah.
they want to be treated as a whole and as a
Yes.
human being. And I
Yeah.
think probably the only constraint on that in terms of the clinician is one of time.
Yes.
But I think, aside from the time issue, that is something that is eminently doable,
Mm,
and fixable, isn't it? So there's a bit of a
yeah.
disconnect there, isn't there?
There is. Yeah, definitely. And the clinicians I spoke to were kind of aware of this kind of perception that some people have of them. They spoke about having to make very quick decisions sometimes and risk assess and all these, and you understand their perspective with regards to how they may come across in that interaction with patients. Clinicians have a understanding that including the patient in shared decision making is really important, and obviously things go more swimmingly and more simply if the patient's on board with what's going on and
Mm.
has understanding and insight into what's happening with their body and their treatment.
I mean, I talked about this a little bit in the previous podcast with Professor Elliott, and he was talking about the shared decision making, and actually now it being like a partnership more than
Yes.
you go to the doctor for all the answers, and you are, as a patient, you're a passive recipient of that information, which I think is historically what's been the case, but
Mm,
actually more so these days with people having access to their own records.
yes.
I think your patients are more educated about their condition. They
Hmm.
have access to details about their condition. That relationship between the clinician and the patient is now a little bit more equal,
Yes.
and should be so from both perspectives. So I think it's,
Yes.
in a way, it's unfair of the patient to have these expectations of clinicians to fix everything, especially
Mm,
within an imperfect system, which we know we live within. NHS
yes.
systems, it's an imperfect system. So to
Definitely.
go in and passively expect somebody else to is probably not entirely fair, and actually to have
Mm,
take more responsibility for our own health,
yeah.
and learning about our own condition, is it's probably right. It's the right time now for that balance to sort of happen. Would you agree with that?
Yeah, yeah, absolutely. And I think that was part of the conversation was around language, and there's
Mm,
issues with language, clinical language in
mm,
particular. But generally speaking, the clinicians that I spoke to wanted that partnership, but saw the value in that partnership,
yeah.
and really did feel that knowledge is power.
Hmm.
In that sense, and it's not just one way anymore. Like you say, it's the patient needs to understand that they are the expert on how they feel, how it
Mm,
affects them, how the quality of their life with treatment and whatever else is going on for them. And I think there is a real understanding of um you know patient patients are people.
yeah.
There is an understanding of that from the clinician's point of view. Yeah.
I asked you what the key points were from the clinician's perspective of giving a
Hmm.
diagnosis. What were the key points from your interviews with patients about their experience of diagnosis?
Yeah, so we there was three really, but there was this big theme of processing loss.
Yeah.
And a lot of people related to this idea that when you're hit with a diagnosis in adulthood, you start to grieve for your former life, the life that you had planned for yourself, the version of yourself without this lifelong condition. The roles that you played in society or within your family, the responsibilities you were able to have that may have to change as a result of your diagnosis, or at least for a time. Um, and this process of grieving for that life, and adjusting to your new life alongside a condition like cardiomyopathy, was a really sort of interesting one. And it sort of, I sort of paralleled it to other models out there. So Kubler-Ross is a very
Mm,
famous model of
mm,
her like processing grief, which was initially, I think, for patients who were given a terminal diagnosis, but then later adapted for when you grieve someone, as in someone has
yes.
died.
Yeah.
Um, so it was very similar to that, but there was key changes that I didn't see anywhere else that I found in our cardiomyopathy population. So, for example, testing.
Yeah.
I had a sort of stage that I called test, and I called them stages. And I don't mean this to be that they are you could move through them in a linear way. You don't kind
Hmm.
of go from stage 1 to stage 7, like boom, boom, boom. But you do kind of just flit about between them in a sense.
Yeah.
And one of the stages that I found was this idea of testing, and it was when patients got to the point in their diagnosis journey where they felt that, okay, I've dealt with this, I've been shocked, I've maybe denied it's happening, I've been really angry, or I've started to blame myself or others. I've, felt this lost sense of identity, had a bit of anxiety or depression, mental health issues. And now I'm testing, I'm starting to turn a corner, but what I want to do is make the invisible threat of cardiomyopathy more visible. And I'm going to do that by wearing watches. I'm going to do that by getting my own blood pressure machines, taking an interest in my notes.
That's really interesting, Jenny. So when you were talking about testing, my mind went to MRIs, echoes, ECGs, blood tests, and that. What you mean is testing the new you,
Yes.
and sort of edging out into the community, into the world with this new identity.
Yeah, yeah,
Ah,
absolutely. Testing the waters in terms of their, what can I do? They would speak in this very sort of particular way, like, what will my heart let me do?
okay.
How much can I push my heart without getting any consequences or, symptoms, and
Yeah.
it's an interesting sort of language that they would use. And
That's really interesting language, actually. What will my heart let me do?
yes,
Um, is almost like an it's almost like an out of body thing, isn't it?
yeah.
Like the heart is now in control
Hmm.
of my actions as a human being, and it will almost randomly, at will, take me one way or take me the other way. That's
Yeah, and
interesting.
that's the second sort of theme that I found is this sense of evolving identity, and part of that is very much the separation of body and self. So people going through this diagnosis, they would kind of feel like, you go through your life and you don't really think about it, um, but then when you get hit with this diagnosis, or in some cases it's particularly bad in those that didn't get any symptoms, because you don't have to have symptoms
Yeah, of
to be
course, yeah.
diagnosed. It could be
Mm,
found incidentally on a scan or for something else, genetics, like you say. um, and for those people, it's just this massive disconnect between their kind of internal experience, the self,
mhm,
and what's going on inside their body that they had no sign, no clue was happening, and it was
yeah,
completely beyond their control. And so they have this kind of separation of body and self,
mm,
where they then have to sometimes, like, then morphs even further into cardiomyopathy being an outside entity that's kind of attacking the body,
okay.
which therefore influences the self or affects the self.
Yes, yeah.
So they have things like, we're running up a hill and I'm moving my legs and I'm trying to get them to go, and my heart's saying no. And it's this sort of interesting language around we. There's
Mhm,
now a community of,
mm,
myself as I am, my essence, my soul, whatever you want to call
mm,
it, is trying to get my body to do the thing that I could just do automatically before.
yeah.
And now the cardiomyopathy is like this outside entity that's making it difficult for my body, which is
Uh,
frustrating the self. Some of them were very frustrated by the fact that it was a hidden illness, was a hidden disability. It was something that almost, if they wish that they had, a stick or something, a
yeah,
walking stick, because that would then legitimize it and announce to the world,
yeah.
be careful with me, I'm feeling fragile right now, or I
Mm,
have something going on with my body that is difficult, that other people can't see. And a part of the frustration was definitely that sense of feeling invisible, which is made worse by this evolving identity, this separation of body and self,
yeah,
because yourself is kind of getting lost in the source when there's the clinicians coming in treating the body. Very
yeah.
much they use words like, oh, he scanned me, or I brought me in to be consented. It's this
Yes.
kind of passive language in a way about their journey through the healthcare system.
Mhm.
And I think their sort of sense of self gets lost a little bit, and they feel trapped, especially when their body is kind of incapacitated in some way. Absolutely.
I think so. Going back to what you were saying about the outward manifestation of an invisible condition, I think that when you go through these processes of, testing, do you think that part of this evolution for the patient is there will be a stage at which the patient becomes a patient and they
Mm,
embody that, patient persona. There is something wrong with me. I am a patient. And then
Yes.
as time progresses, and as links with the medical profession lessen, and
Mhm.
we learn to sort of manage the condition and with live with
Yes. Absolutely.
cardiomyopathy,
Yeah.
that then you become less of a patient, and then you sort of gradually realize that the self
Mm.
that has got lost in this phase of diagnosis isn't lost, it's just been
Mhm.
slightly suppressed for a while and returns. Is that a fair sort of explanation of that process of sort of being a patient and then coming through that and reimagining your new self?
Yeah. Yeah. No, I like the way you put that. I think that's very, yeah, I think it does ring very true. It's the final step on that sort of processing loss was this kind of idea of acceptance, and that's such a broad sort of term, but
Mm,
acceptance being that when we go through this evolving identity phase, there's this process where you do kind of separate body and self. You do consider there to be like an outside entity in cardiomyopathy that's affecting the body and
mm,
ergo the self. And then the healthcare aspect as well, where the healthcare, you know, are treating the condition and treating the body, not always treating the self from the patient's perspective.
yeah.
And, you know, eventually though, there is this level of acceptance where you go through this process of testing. Well, what does this mean? And you get to know your body. You
Hmm.
get to know, become familiar with the sensations that are coming up for you when you do certain things, or where your limits are physically. You will get to know these things and understand your particular body and cardiomyopathy and treatment, to the point where you then feel, okay, I'm no longer just a patient.
Yeah.
I'm forever changed, but I am me with my set value system. I'm still me and can still live to these values, but maybe in a slightly different way now.
Mm,
I will always have interactions with the health system. They become a part of my lived experience now forever because of this condition. And so does the whole idea of cardiomyopathy and what that means. But you kind of, like you say, you live alongside of it, you
mm,
live with it at a certain point. But yeah, this sort of very tumultuous kind of journey that people go on to get to that stage is really fascinating. Absolutely, yeah.
So we've looked at the clinician perspective, we've looked at the patient perspective.
Mm.
Did you find that there were any areas where both perspectives overlapped?
In terms of them both feeling very similarly about something, um, two areas spring to mind. So one is education, information resources, and the fact that there just is this massive gap. And this was felt by both patients and clinicians, that there's just a massive gap in terms of education.
Yeah.
And there's a lack of peer support that they can give for their patients. There's a lack of support groups, a lack of all sorts of, and it brings me on to my second point, which is mental health support.
Hmm.
Patients and clinicians both, I think, in fact, I think clinicians felt even more strongly up to in some points,
Yeah.
that there's this massive lack of mental health support for newly diagnosed patients,
Yeah.
and it's at a time where it's so important, um, and there is such a clear link um, in the research now about cardiac health and mental
Mm,
health.
mhm.
And I think, the cardiologists are very aware of this and the patients are very aware. But from the patient's perspective, they don't realize that it's normal. They don't realize that
Yeah.
that part of that step process of processing the diagnosis, processing the loss of their former life, is anxiety and depression, is some sort of, maybe not clinically, clinical
Yeah.
levels,
Yeah.
but some sort of fluctuation in their ability to deal with life, deal with stress.
Yeah. Yeah. And I absolutely agree with you. I think that moment of diagnosis is so important as to how you then frame mentally
Hmm.
how you're going to live with this condition.
Yeah.
And if it's presented to you in a negative way, then you start your journey with this condition with a negative mindset.
Hmm.
If it's presented to you in a positive way, I think with most cardiomyopathies these days, the outlook is probably brighter than it's ever been.
Mm.
And that is a positive thing. And if people are given skills, information, knowledge to be able to manage their own condition and how they react to having that condition,
Mm.
then they will start that journey of living with
Yeah.
the condition in a much, much better place
Oh yeah, definitely.
than if it's, negatively given.
The final kind of theme that I found, which was about patients just wanting certainty,
Yeah,
which is really interesting because clinicians can't give that.
no.
That's not something that they have ready to give.
They can give certainty over some things.
Hmm.
So, for example, they can be certain about a diagnosis. I guess what's harder to be certain about is prognosis.
Yes, yeah, definitely. And I think it's interesting though that you say they can be certain about diagnosis, and for the most part, absolutely, yeah, definitely. But there was definitely some cases where they aren't, they start off thinking it's one thing, and
Yes,
through that process of differential diagnosis, or
absolutely. Yeah,
it then turns out not to be. But and from the patient's perspective, they can then interpret that as, oh, well, they're changing their mind every 5 minutes. But yeah, I think there's certain things that they can be reassuring about. They can be more certain. I don't think they can give absolute certainty, and so it puts them in a really difficult position when patients want that, or are seeking that in everything they
yes,
do.
yeah. They're very, very hard. Jenny, it's been absolutely fascinating talking to you today. Maybe just to sort of wrap up today's conversation, what would you say is the sort of the key take home message from our conversation today around um, sort of diagnosis from both perspectives, so from the clinician's perspective and the patient's perspective? What are the key things that we need to consider?
I think the focus at the moment is very much on the the relationship between clinician and patient. That's a very common conversation people have, and the discourse around that is quite well established, I think. But actually, what does diagnosis mean for the person? What does it mean for them personally, and what kind of impact does the diagnosis has on their sense of self, on their mental health, on their ability to lead a fulfilling life? And I think that's the main sort of conversation that I think is important to have is, how do we improve the experience for the person, both the
Mm,
clinician and the patient? I think time is massive. Time
mm,
came up again and again, and clinicians just wish they had more time with their
yeah.
patients to support their patients.
Jenny, it's been absolutely fascinating. I hope we'll speak again.
Yes,
But in the
definitely.
meantime, thank you for joining me today.
No, thank you so much for having me.
Thanks for listening to this episode of Cardiomyopathy Conversations. Please remember, any medical information contained within the podcast should not be used as a substitute for advice from your own doctors. If you have any concerns over your own condition, please do consult your medical team. Views expressed in the podcast do not necessarily represent the views of Cardiomyopathy UK, but are the views of the individual host or speaker and is intended for a UK audience. Cardiomyopathy UK does not accept responsibility for any actions taken after listening to this podcast.